Welcome to Module 3 of Identifying Patients in the Sepsis Gray Zone. This is Module 3, which was built sequentially after Modules 1 and 2, and so we would encourage you to take Modules 1 and 2. They're free after all, but you can pick and choose and take the modules as you please. Today, we are joined by Dr. Robert Bach and some research that he did, and we'll then continue our discussion on navigating the gray zone of sepsis diagnosis. So Dr. Bach is a professor of Department of Internal Medicine and Division of Pulmonary and Critical Care and Sleep in Chicago, Illinois. And thank you, Dr. Bach, for joining us.
Thank you, Michael. I want to at least give credit to my institution. I'm at Rush University Medical Center in Chicago, and I have been involved in sepsis research through a vast majority of my career.
Hi, I'm Dr. Jasmine Bonder. I'm an acute care nurse practitioner, and I'm on the board of advisors for Physician and Patient Alliance for Health and Safety.
Hi, I'm Dr. Adam Bonder. I'm a board certified emergency physician in San Antonio, Texas. Excited to talk about sepsis.
Great, thank you, guys.
So it's my distinct honor today to review some research study that was sponsored by Immune Express and was something that I had the honor to be part of. We were not the only site involved. We were part of two prior studies. One was called the Venus study. Second was called the Mars, which was actually done on a product that was called SeptiCyte, which was not the rapid form of this sepsis determination study, but it became clear that the industry needed something that was more rapid. So SeptiCyte RAPID was developed, which was designed to evaluate patients in real time to see if there were immune response genes present in the blood that could identify patients that had a high likelihood of having sepsis. And that gave rise to what will be termed the Neptune trial, and we're going to review the results of that. So why are these studies being conducted? Well, you've just heard a lot in the prior modules that the systemic inflammatory response can exist from a variety of conditions. And we all know that sepsis has great import in the sense that we have certain actions that are needed if we're going to have improved outcomes for our sepsis patients. And we'd also like to be able to identify a population of patients who actually need antibiotics and not just treat everyone who has a systemic inflammatory response with antibiotics so that we don't fuel the development of multi-drug resistant organisms, which will have a very detrimental effect on society and just throw antibiotic stewardship away. So Immune Express and other companies have been working on ways to hone down who actually has sepsis as a cause of the inflammatory response versus non-infectious disorders. And we've realized that there right now is no perfect sepsis test strategy, because for a perfect strategy, we want something that is infallible and will give you a very rapid response within minutes so that you can start your antibiotics within minutes of making that diagnosis. But sometimes you have to go in small steps. So the studies I'm going to review for you today look at patients who present with clinical signs and symptoms of inflammation that could be systemic inflammatory response from infection versus systemic inflammatory response from some other cause, such as pancreatitis, trauma, etc., and be able to use this data to make a determination of who has sepsis and then start your resuscitation, your antibiotic therapy, and all of the different components of our sepsis treatment regimen so that we have good outcome.
I would like to encourage listeners to scan the QR code for the research that Dr. Bach did in case they would like to read the research in more detail.
Thank you for pointing that out. So the purpose of the SeptiCyte RAPID study that you just scanned your QR code was to evaluate a molecular test that will look at some response genes elaborated by white blood cells to help distinguish somebody who has sepsis from somebody who has a non-infectious systemic inflammatory response. These genes are produced by white cells as they recognize various organisms, not specific to bacteria or virus or fungi. And the organism doesn't have to be present in the blood in order for these response genes to be detected. And what you get after an analysis that takes about an hour is a score will come out from 0 to 15. The higher the score, the more likely the patient has an infectious cause of sepsis. And the lower the score, the less likely the patient has a infection causing sepsis and more likely a systemic inflammatory response to something else. So the study actually was a two-part study. The first part is I mentioned the prior studies of SeptiCyte scores had 356 participants that had data that was collected and blood still sampled so that it could be then sampled with the SeptiCyte RAPID assay and all the clinical criteria of those patients still utilized. And then the Neptune study was a prospective trial designed to identify adult patients who were admitted with a systemic inflammatory response syndrome type of presentation into the ICU, and they had a sample obtained, and the clinical data was then assessed and then adjudicated by a panel of 3 blinded expert physicians in pulmonary critical care to ascertain whether they had sepsis or some other cause of a surge response. And you can see how the data moved along through the patient samples, the physician panel, and then the validation was then put together. And you can see that they produced some actually pretty decent results. Now, again, it's not a positive or a negative like a pregnancy test, but you get a sort of a range of positivity in the score, which when you compare the range under the receiver operating characteristic score, you see the SeptiCyte RAPID score tends to be in the realm of 82 to 85% likelihood of identifying a patient with presumed sepsis. And you can see a negative predictive value that is pretty high of 0.91 for low risk and a positive predictive value of 0.81 for the high risk bands. And in comparison to other tests that have been out there, biomarkers for presumed identification of sepsis, like lactate or procalcitonin, the SeptiCyte RAPID score seems to outperform those scores. And this SeptiCyte RAPID score did seem to perform well, depending whether you use the Sepsis 2 definition or the new Sepsis 3 definition. So while it's not perfect, it is out there and may have a role for sepsis management.
So obviously a valuable tool, but not maybe one that could be used for triaging, or could it be used? What are your thoughts on that, Dr. Bach?
It's a great question. As I brought out, the test was set up and both aspects, for the initial as well as the subsequent test of SeptiCyte RAPID for patients who were destined to go to the ICU. So these are adults. They weren't pediatric patients. They weren't patients on the floor who were going to stay on the floor. So we don't know how well it works as a triage tool like people have used lactate, procalcitonin, or even CRP for triage. So that is data to be further pursued in the future. I also should have remarked that if you're going to use this as a tool, you have to use it not in its own regard, but along with clinical assessment of the patient and with all the other clinical tools you're going to use to make your diagnosis of does this patient have sepsis versus a SIRS response. So the studies demonstrated that SeptiCyte RAPID can accurately estimate sepsis probability in critically ill patients, and that this actionable result, which comes within about an hour, can aid your clinical diagnostic strategy to help you in the situation where you are uncertain whether the patient has indeed an infection causing their SIRS response versus a non-infectious cause of SIRS. That taken, I would also emphasize that if you have a patient who presents with septic shock type picture, you do not need to run a SeptiCyte RAPID to help you determine does this patient need antibiotics. That's the situation where you want to give your antibiotics as quickly as possible. That's where administering antibiotics, doing your resuscitation, doing your source control, getting your patient into sepsis management as quickly as possible leads to the best outcome, and delays impact adversely on that outcome.
Could it be used to help you decide whether antibiotics should be administered or not?
Where it would help is in this situation where you are uncertain if this patient's presentation is infectious versus non-infectious. You know, the patient who's not in shock, who you're not certain that you've identified a source of infection or a site of infection, and you have to decide, do I give antibiotics or not? And you have that 3-hour window in our surviving sepsis guideline. Having a SeptiCyte RAPID and have that result combined with your clinical acumen and clinical assessments can decide there may be utility in getting this test to say, yes, this patient does need antibiotics. It may also help out if you started antibiotics rapidly and the patient then had the SeptiCyte RAPID come back very low. Maybe you'd at least reconsider whether you give a second dose. That actually needs to be further substantiated over time. I'll say it's validated as procalcitonin for early curtailment of antibiotic therapy. And even with the procalcitonin, remember that's in conjunction with a clinical response of improvement plus a decrement in your procalcitonin level over time, usually at day 3 or 4.
So you've alluded to, obviously, the patient that comes in is clearly in septic shock, and then there's others that are clearly not in sepsis, and then there's this sort of middle area. Do you think that there's an ideal type of patient that should be administered the SeptiCyte test?
I think the ideal patient is in the situation, and it's actually more common than we actually give it credit for, who presents just not looking well to the ED with some of the abnormal vital signs we see with the SIRS response, and there isn't a rapidly identifiable site of infection or source of infection, and you are truly not certain whether this is a SIRS response to some other process or if there could be infection going on, that's where a SeptiCyte RAPID may help swing you into a more investigative type of evaluation of that patient, or even to starting antibiotics early while you're awaiting the results of that investigation to figure out, does this patient truly have a infection causing this clinical presentation?
Sounds like an excellent additional tool to be included in the clinician tool belt. Any cautions you would have for folks using this test?
I think the caution is with any test using it by itself. I think the future will probably show that we have a number of potential biomarkers that maybe taken together are much stronger predictors of what's going on than using either one as a standalone by itself. And clinically, what we've learned so far is we don't want to miss the septic shock patient and not start our antibiotics and our resuscitation as early as possible. But yet, in those patients who are not in shock, who you have time to actually think and make a clear decision, this is another part of your toolkit, as you point out, that can better hone down our ability to use antibiotics judiciously and not compromise our patient's overall clinical response to actual treatment.
And as you said, you've been getting it within an hour, which satisfies the need for immediacy. Obviously, as a patient or a patient family, you want to make sure that your loved one is taken care of as quickly as possible without an excessive or inappropriate use of antibiotics, if I could put it that way.
I agree with you. That's a good summary.
Thank you so much. Anything else to add, Dr. Bach, on the SeptiCyte test you'd have for folks?
No, I just think the future will probably show additional refinements of this test and other tests to try and find that magic sepsis test that would be a yes or no and be able to quickly diagnose the patient who needs our full force of sepsis resuscitation initiated as soon as possible.
Well, thank you so much, Dr. Bach, for your research and your insights today on this module.
Well, thank you.
And so let's talk about the unfolding case study of patients in the gray zone. Adam and Jasmine, let's go to a patient case study which features our first patient. Adam, would you like to talk to this 80-year-old male patient?
Absolutely. So this is a classic presentation of what we would see in the emergency room. This is an 80-year-old nursing home patient who comes in with a confusion. He's got multiple medical problems and comorbidities, including high blood pressure, diabetes, and urinary retention, for which he uses a catheter. Last seen normal about 12 hours ago. And since that time, he's been increasingly confused. So we start to evaluate him in the emergency room for possible scenarios of what could be causing his confusion. On his presentation, he's a little hypertensive at 150/90. Heart rate's a little fast as well as at 120. Could some of this be attributed to his temperature of 101.3? And then on exam, he's in mild distress, but alert only to himself, which is off of his baseline. There's no other focal neurological deficits that we see, and there's no rash on his exam. His lungs are clear and his abdomen is soft with some tenderness that appears to be in the suprapubic region.
I think it's important to recognize also when we have any type of foreign products like an indwelling catheter at play, we think of something foreign now it has entered the body. It's usually one of the first scenarios for you to think, what could have else have entered at that time? Given the patient presentation, also their age, you have to think about what infection now is introduced into the body and could be presenting in these symptomologies.
So when we start to think of it, exactly what Jasmine brought up is we have to think about, well, what foreign substance could be causing this or what could be contributing to his confusion. And there's a wide range of presentations to cause him this confusion. And some of those are included here, including stroke, pneumonia, urinary tract infection, or an overdose, all of which are very common in this age group, especially with polypharmacy and multiple medications that they take. So when we go through this and we're talking through, well, what is the most likely cause? Well, you have to piece together the whole patient picture, which includes his fever, his tachycardia, the fact that his physical exam was rather benign other than some suprapubic tenderness. His lungs were clear. There was no rash. So in this case, the most likely source of the patient's symptoms would be his indwelling catheter and the urinary tract infection.
You named it correctly, Adam, urinary tract infection. And those learners who have joined us for modules 1 and 2 We have talked about elderly patients that have a urinary tract infection in previous modules. So this is something which comes up a lot with elderly patients in particular.
Absolutely. And I think it's important to take a holistic approach with care, clinical judgment, and clinical assessment. When you're recognizing the patient, we see a foreign object being used to help him with his everyday life. We have to recognize what is going to be the best plan of care. And it really is a holistic approach. We notice that there's a fever. How can we get an antipyretic on board to drop the fever, give some more comfort for the patient? How do we recognize that an early infection is on board? We have, again, the tachycardia, we have the hypotension, we have the fever. And then again, the Foley is in place. So really, we're looking at this holistic picture and taking clinical judgment to help remove and mitigate any of these concerns. So when you're thinking about your next best course of action with this patient, it's a holistic approach. Take each step that is a concern for the patient, the current presentation, and support them.
But obviously, Adam, you'll want to talk about sort of, it's great if it's just a urinary tract infection, but it could be a host of other things too as well.
Absolutely. The top three causes of sepsis in this patient population are either cellulitis, urinary tract infection, or pneumonia. So evaluating appropriately for all of those is extremely important to make sure we're not missing any other causes, and therefore can address our course of action most appropriately for this patient. And that's what this next question is about, is what would be the best course of action for this patient? Would it be treating the fever? Would it be sepsis order set with the antibiotics, or taking out the Foley? And in this case, it's actually all of them. And it's important, what Jasmine has highlighted is the foreign body harbors bacteria. And so removing that foreign body is going to be essential in order to make sure that we remove as much of the infection and the antibiotics can work as appropriately as possible. And as well as treating the fever, so you decrease the metabolic demand of the patient, therefore less fluids, more likely to survive sepsis if they have less metabolic demands that we are trying to tailor our therapy to.
And I think it's important to recognize that addressing vague symptoms really are important to prevent progression. Recognizing just a fever, minor change in neurological status, really acting with these initial attempts will prevent SIRS to going to sepsis, to severe sepsis, and then into septic shock. Really recognizing that at early stage is really practicing preventative care.
And so here we have our next patient. This is a 60-year-old female. She's got hypertension, COPD, frequently comes in with COPD exacerbations, meaning she's getting multiple rounds of steroids and albuterol. She comes in for weakness. And for the past few days, she's been too weak to get out of bed. They're associated with some abdominal pain that has just been lingering for the past few weeks, mainly epigastric in nature. She's tried a lot of over-the-counter medications that have not resolved her symptoms. Her vital signs show that she's a little hypotensive at 90/50 and a compensatory heart rate of 130. Also a compensatory respiratory rate of 22. Temp is 96, which is on the borderline of low. She's mild distress and is uncomfortable. She's definitely pale and cold on exam, but does not have any rash. Her lungs have coarse breath sounds throughout, which can be consistent with her COPD, and her abdomen has some mild epigastric tenderness.
I think that there's a lot of etiologies currently at play. So you really, again, need to take the full clinical picture and really see what is the past medical history? What are they susceptible for? What are further complications that can happen with their previous diagnosis and their current presentation? Some highlighted points is that there is a diagnosis of hypertension and COPD on board. So we understand now what organ systems already need additional support. Additionally, the patient has tried multiple over-the-counter medication without relief. And I want to really put a star on that they've already attempted their first preventative measures to be able to feel better, and it's not getting better. So they presented to the emergency department via the private audio for weakness. So they're clearly getting worse with no relief of over-the-counter and very accessible medication. So what is a possible cause of the patient presentation? Could it be severe sepsis, overdose, GI bleed, heart attack? At this time, the most important thing is to rule out all of them. All the above are applicable given the current state of their presentation and their past medical history.
Yeah, and this touches on the variability of these presentations in this age population. The GI bleed is what we're mainly hinting at here, especially given the fact that she's had multiple COPD exacerbations, therefore multiple rounds of steroids, and likely to develop a gastritis because of it, as well as the duration of symptoms that she's had. Heart attacks also present with epigastric abdominal pain in the elderly female population. So that is one that we would absolutely want to consider as well, and can cause that hypotension. As we've been discussing, severe sepsis is always a possibility. Her temperature was low, her blood pressure was low, and she meets this SIRS criteria. So it's one of the ones that we wanted to evaluate fully for. But in this case, I think that it's important to recognize the entire clinical picture can encompass all of these as a possibility.
And then when I think about what next steps, and we're, as you said, Adam, we want to differentiate between severe sepsis and GI bleed, both very pressing concerns for this patient and the current presentation. We really want to be able to do, again, a full clinical picture, full clinical oversight. And all of these are great choices. But what is going to be the first initial one that we want to be able to draw and be able to tell us where their current state is at? We can do blood cultures, which will tell us what's growing in the body. We can do a CT scan of the abdominal, but that may take 45 minutes. A lactate and skin turgor. Lactate is great for us to be able to see the hydration and the overall state and the exertions the muscles are taking. Skin turgor will tell us dehydration, but ultimately we want to see if this is an active GI bleed and what's the current status of their complete blood count. We want to see, are they having a fever? Are they compensating in any way? Do we have a shift in their differentials to see, are they having a infection presentation? Are they having any concern with their anemic status? And again, we really want to see, is there a current and active bleed happening that would change the next steps?
So Jasmine hit on this exactly. The CBC and the occult blood rectal exam will give you the fastest differentiation between our differential diagnosis. So that would be where we'd initially start. All of these are important in evaluating the possible etiologies of the patient presentation. However, the CBC and the occult blood rectal exam would be the fastest in order to diagnose the GI bleed which the patient is experiencing at this time.
Also, while she's presented in the ER, this is something that's easy and able to do, that the patient comes in presentation, you understand that there's multiple comorbidities, drawing blood and doing a bedside exam can give you some really good prognosis of what they're currently standing and what next steps need to happen, and ensure to encompass full care for them and really help you point the directions of what is next for her. What is something that we can do immediately to help prevent sepsis from occurring?
So next is our 40-year-old female patient with a history of diabetes who's been in the hospital for the past 2 days, recovering from cholecystectomy that she had for cholecystitis. The nurse is called to the room as she's having some now worsening abdominal pain. Her morphine isn't improving her symptoms, and that she just feels unusual.
I feel like for us, when you hear a patient that says they feel off, all the flags should be going off, really, for you to recognize if they're not feeling well, something else is going on.
And so we start with the vital signs when someone has these concerns initially. And what we find is that she's borderline febrile at 99.8, a little on the hypotensive side of the blood pressure of 100/50, and her heart rate's also borderline again. Again, hinting at this gray zone that we've been talking about throughout this presentation of diagnosing sepsis or other etiologies. And on exam, she is complaining of some pain, but skin is dry without rashes, her lungs are clear, and her abdomen is soft with just some epigastric tenderness.
And I think it's important to point out what Dr. Bond originally said, that there is this gray zone we really want to prevent, and the importance of addressing vague symptoms to make sure we're not making the etiology get worse. And there are simple things that you can do to really act now so the patient doesn't get into a severe septic state. So when we talk about what should be the first concerns for this patient, should we think stroke? Should we think heart attack? Should we think infection? Should we think GI bleed? I think it's important to recognize what was the original concern. The patient came in, we know that they're diabetic, we know they just had a cholecystectomy. What would be your next thought?
Well, you would lean towards the most likely cause. So what were the most recent changes in the patient presentation? In her case, being the recent surgery for cholecystitis. Leading that there's been, as we talked about with the other patient presentations, to the understanding that there was a foreign object that was involved with the patient's presentation, as well as already an infection. So that would be my first concern, especially with the patient's borderline being febrile and vital signs that fit into the gray zone. you would expect, some focal neurological deficits or some chest pain for stroke or heart attack in this age group, although they can present atypically. However, with common things being common, especially post-op, you'll get worried about post-op infections, the most common causes of infection after surgery, including pneumonia, cellulitis, and urinary tract infections. So in this case, that would be my main concern, is a possible infectious etiology, given the fact that she was just admitted to the hospital for an infectious etiology.
Yeah, and I think it's also great to recognize when someone comes out post-op, vitals are critical to show us if there's anything compensating. And as we recognize with the patient, they had very vague symptoms, but their vital signs were telling us a lot more. Their heart rate was a little bit on the high side. Their blood pressure was a little bit on the low side. And really the biggest endorsement they've had is just pain and not feeling great. And so these are the gray zone that we are addressing during this sepsis module, is recognizing when a patient is endorsing these concerns and things are just leaning a certain way. This is an opportunity to act fast and make sure it doesn't progress, really practicing preventative care so we don't get into the sepsis criteria. Especially if a patient recently had a surgery, they're just at higher risk for infection. So knowing the big clinical picture, acting fast really prevents patients from getting a severe septic state.
So this is exactly what Jasmine had discussed, is it's the early diagnosis of the sepsis gray zone to preventing further complications and decompensation. So recognizing the signs and symptoms of the gray zone is extremely important to improving patient outcomes. And then treating those underlying etiologies and preventing further decompensation are what's going to improve patient outcomes overall. And there's no magic solution to this. There's nothing that's going to absolutely point you one way or the other. It's using your clinical judgment and the tools available to you to help define the clinical picture and to tailor your approach appropriately to the patient presentation. So as we had talked about heart attack and stroke being a possibility as well, making sure that you're doing a good physical exam, as well as considering the most likely etiologies given her most recent surgery, are important in distinguishing the causes of the patient's presentation.
And when you hear sepsis gray zone, think about prevention in that state. When an individual is endorsing concerns, change of condition, we're really wanting to act preventatively so we don't get into an acute state that requires further intervention medically. So using your clinical judgment, using best practices, and having consideration of how the patient feels at that time can ultimately help health outcomes. Helping patients, making that the forethought of all of our clinical judgment is ultimately why we all come into medicine. And again, prevention is key for success.
So here's some recommended readings. Dr. Bach's research. I would highly encourage you guys to scan the QR code and view that as well. Chess recently put out a video diagnosing sepsis, which is very interesting as well. So please use your phone to scan the QR codes and it'll take you to those two resources. So thank you, Jasmine and Adam, for wonderful presentations on these patients and discussion about them.
Yeah, thank you for having us and thank you for the advocacy.
Thank you.